all of us here at Medical Advantage Group, thanks so much for joining us again today. Our latest webinar, HCC and Risk Assessment Coding. Candace, if you can go to the next slide, we can just cover some housekeeping things here. One more slide, please. So we've got a number of people listening in here today. So we're going to keep all the phone lines muted during the actual presentation. We will be pausing at the end, however, for question Q&A. So please just use the little control panel, go to webinar control panel to submit any questions you may have as you think of them, and we'll address them as we go. Also, as always with these kinds of things, after our session today, all registrants will get a copy of Candace's presentation as well as a recording of the entire session. Next slide, Candace. All right, so before we get into the actual agenda, I wanted to just take a moment and introduce Candace. It's just a fantastic opportunity that we have with Candace here today. She's a director of Medical Advantage Group Revenue Cycle Management Services. So she oversees all medical billing and RCM services that we're providing to our clients. This includes things like chart audits, workflow analysis, billing support. In terms of real-world experience, Candace has worked in reimbursement areas at St. Mary's of Michigan, as well as McLaren Health System. She also serves as an adjunct professor at Davenport University, teaching EHR systems, practice management systems, medical insurance billing, and other topics. Candace is a regular presenter at healthcare industry conferences and just brings a remarkable wealth of knowledge in this area and especially real-world experience. So with that, Candace, please go ahead and take it away.
Thank you, Bill. So today we are going to discuss an introduction to HCC and risk adjustment. We're going to discuss fee-for-service coding versus HCC coding, coding rules, as well as common errors within coding for HCC. But before we get started, we are going to do a quick poll.
Okay, thanks, Candace. So you just see on your screen there, we're just trying to get a sense of who all is with us today in terms of your role. So please just point and click if you're office manager, biller, RN, LPN, physician, or other. We can try to tailor our message accordingly. Okay, this is interesting. So it looks like about a third of you are billers, and the overwhelming majority, some office managers, 9%, 64% are other. Interesting. Very interesting. All right, so Candace, please go ahead.
All right. So the first thing we are going to discuss is HCC and risk adjustment. So what is risk adjustment? This is a process where health insurance plans such as Medicare and ACA are compensated based on underlying health conditions of enrollees. So risk adjustment is a modern methodology that accounts for known and discovered health data elements and levels comparison amongst the wellness that patients have. So all risk adjustment models use diagnosis codes to determine potential patient level risks. Additional elements that are taken into consideration are age, gender, disability status, financial status, the insurance, the place of service, if someone's on a disability, or if they're enrolled in hospice. What is HCC? So HCC stands for Hierarchical Common or Condition Categories, which is a sorting mechanism for chronic conditions that assigns a payment value on care of a patient with a certain condition. There is also RX-HCC, which is separate consideration of prescription costs for a patient with a specific condition. So the RX HCC may be more or less than a regular HCC, or if an HCC is assigned to a diagnosis, it may also not have an RX HCC. We'll talk about all that a little bit more. Types of risk adjustment plans. So there are Medicare Advantage plans, CDPS, which stands for Medicaid Chronic Illness and Disability Payment System, as well as risk payment pools. So with the private risk pools, all of the premiums go into a pool and are redistributed based on population of the patient's risk score. So how does HCC work? So the insurance company pays the physician for services performed. If chronic conditions are properly documented and coded, CMS pays the insurance company money for the patient based on the risk adjustment score. So not documenting or not coding chronic conditions actually deprives the insurance company of correct reimbursement when those conditions contribute to medical decision-making and increase the services provided to that patient. In addition, there is governmental oversight that does hold the payers responsible for the providers consistently and accurately coding. So each diagnosis that is costly to manage is assigned an HCC. So down below, there's a table. You'll see diagnosis A0103, which is assigned HCC 115. A0104 is assigned HCC of 39. So keep in mind that the diagnosis list is updated yearly, so practices should make sure that they review this list on a yearly basis, as there are diagnoses that are added or removed from CMS on a yearly basis. So every diagnosis is assigned an HCC, and then every HCC actually has a payment adjustment score that is taken into consideration. These scores do change based on the diagnosis, if it was established, if the patient has any other influencing factors, such as if they're on hospice or they have end-stage renal disease. So on the slide, you will see for HCC 34, if the patient is on a non-dual Medicare plan, so they just have a Medicare plan, they would qualify as a risk adjustment score of 0.276. If they're disabled and they had the HCC of 34, it would be 0.678. So how does this relate to CPC Plus? CPC Plus patients receive a risk-adjusted monthly care management fee. So CMS assigns beneficiaries to a risk tier based on the individual's HCC score, and then scores are generated for all beneficiaries and they are updated on a yearly basis. So the beneficiary scores will determine which risk quartile the beneficiary is assigned. So Track 1 practices will receive a care management fee that averages $15 per beneficiary per month. The higher the quartile for the beneficiary, the higher the monthly fee. This is why it's important to document all chronic conditions and code to the most specific diagnosis that is possible. In addition to the per beneficiary per month fee, practices will be paid a fee-for-service rate for covered E&M services. So on this slide, you will see a CPC Plus care management fee chart. If a patient falls into the Tier 3, which is the third quartile for HCC, their per beneficiary per month payment would be $16 if they were on Track 1 and $19 for Track 2. If they fell into Tier 2 and they were in Track 1, then that would be $8 per beneficiary per month that was assigned. Our fee-for-service coding versus HCC coding. So there is a shift in focus when you are coding for fee-for-service versus HCC coding. So with fee-for-service coding, most coding is done for medical necessity of the visit. Within HCC coding, this requires a wider focus, reporting any chronic conditions that are documented and have an effect on the patient care. So we see a lot where a patient may come in and they may have Alzheimer's, which is requiring a friend or family member to obtain the history and discuss the treatment plan, making sure that that information is in your progress notes and any other documentation that the patient may have Alzheimer's. All of that will help when you're coding your chronic conditions and ensuring that practices can try to meet a diagnosis that has an HCC assigned to it. Some of the similarities between HCC and fee-for-service coding: each individual encounter must be able to stand on its own. The goal should be that you want to select a diagnosis that is as specific as possible, as well as reviewing coding guidelines on a regular basis to ensure that we are following all of the guidelines. In an audit, each data service documented must support the diagnosis. So a risk adjustment auditor cannot refer to any other visit notes or ask the provider for clarification. So if it's not documented, it wasn't done. Some of the differences between fee-for-service and HCC coding: each chronic condition needs to be reported once a year, or the payers will miss out on additional risk adjustment reimbursement. In fee-for-service reporting, medical necessity is required. In HCC coding, meet is required. And we'll talk about what meet is in just a few minutes. It is recommended that patients have a visit with providers once a year to review any chronic conditions, identify care gaps, and create a plan for the upcoming year. January of each year, the risk adjustment slate is cleared. So if there are chronic conditions that are not coded from the following year, they are viewed as resolved. The most common HCC diagnoses are diabetes mellitus, cancer, heart arrhythmias, ischemic heart disease, COPD, which is chronic obstructive pulmonary disease, congestive heart failure, vascular disease, angina, stroke, and rheumatoid arthritis. So now we are going to discuss some of the coding rules for HCC. So all diagnoses that are coded have to have MEET, and MEET is an acronym for measured, evaluated, addressed, and treatment. So from the measurement standpoint, it's going to be your signs and symptoms, your progression or regression. From the evaluation standpoint, they're going to look at test results in response to treatment. If things are addressed, there should be ordering of tests, referrals, any reviewing of medical records would count as addressed or assessing. And for the treatment, that would be prescribing medications or any additional therapies. So at least one of the components of MEET must be in the note. So simply pulling a problem list forward will not have the MEET necessary to report the code. So an acceptable problem list must show evaluation and treatment for each condition. So if it doesn't have MEET, it shouldn't be coded. The MEET must be specific and have a direct link between the disease and the MEET. Your MEET can list any negative results or findings. It has to be documented in the same data service, and it can be documented in any part of the progress note. Casual relationships. Proper documentation is imperative of casual relationships. So a lot of times in a medical record, you'll see a patient is diabetic, and then somewhere else in the record, they will indicate that they have neuropathy. But it is imperative to know if these relationships are casual. If one is due to the other, that will have an impact on the HCC payment. Some common coding errors that we see within HCC is the disappearing diagnosis. So we talked a little bit about how if you had diagnoses and every year that slate is wiped clean. So having a meeting with a patient to identify chronic conditions, that's important that you're capturing all of your diagnoses that are still existing for that patient. So one of the most common ones is morbid obese. So if a patient was diagnosed as morbidly obese in 2015 and the medical record actually states that they are morbidly obese, the patient's coming back now and they're still morbidly obese. The providers even discussed weight loss with the patient, but there's only a BMI reported. So that could have been taken back to the provider to confirm, is the patient still considered, morbid obesity? And if so, then that should be coded within the claim itself. You cannot add a diagnosis of morbid obesity. It has to actually be documented, and that it should be reported at least once a year, so it will count from the HCC standpoint. Some other popular offenders for disappearing diagnoses are amputations, transplants, Down syndrome, HIV status. So providers forget that they need to be continuously documenting that these conditions exist and if there's an impact that it has on any other service that the patient's receiving. Using the most specific code possible. This is an issue with fee-for-service coding as well as HCC coding. So this can make the difference of whether a code maps to a risk adjustment or not. So making sure that the billers and coders are reviewing the diagnosis selection and then correcting it if there is something more specific that should be used based on the documentation. So on this slide, we have F32.9, which is an ICD-10 code for major depressive disorder, single episode unspecified. So the HCC group on that is 0, which means there's no HCC assigned to it, and our risk-adjusted factor is 0 as well. However, F32.0, which is major depressive disorder, single episode mild, maps to an HCC group of 58 and has a risk-adjusted factor of 0.395. So by the provider just adding that it's mild versus unspecified, you're now eligible to report a diagnosis that has an HCC group with a risk-adjusted factor associated with it. Some common errors are misdiagnoses. So looking at the diagnosis documented somewhere in the record is one of the common errors that we see. A lot of times all the diagnoses are documented in the assessment and the plan, and those generally are coded on a claim. However, there are times when other diagnoses are clearly documented elsewhere in the report, and the fact that they're not specifically carried to the assessment or plan doesn't diminish their existence or the need to capture them as a current diagnosis or morbidity. So those should be captured for risk adjustment purposes as well. Some additional common errors, not documenting due to. So if a patient has neuropathy and it's due to diabetes or due to alcoholism, we need to make sure that we are documenting that relationship so that we are able to code to the most specific code as possible to ensure that we are eligible for an HCC assigned diagnosis. History of is another one that is commonly misdocumented. So this should only be used for a condition that has completely resolved. Coders cannot code for a condition documented as history of. It is a good idea on a regular basis to review the ICD-10 guidelines that are in the front of the ICD-10 book to make sure that there haven't been coding rules that have changed and the office isn't aware of, because those will have an impact on the diagnosis which is assigned, which will in turn have an impact on the HCC that is associated with it. Some additional common errors is documentation of the medication list. So we need to review the medication list and state that it was reviewed, including an indication that the patient medication list was reviewed on the date of service will add meat to your progress note for chronic conditions. The other thing we want to do is, as coders, make sure that we are not making assumptions or filling in the blanks. So if it wasn't written down, the coder cannot code to it. So we can't make assumptions. The provider actually has to document in the record all of the information so that when the risk adjustment auditor is performing the audit, everything should be clearly identified within that progress note for that data service. providers must document with words, not codes. So we see this a lot where the providers will put in the codes, and those are not documentation. They actually have to use words for the diagnoses and documentation. So it's got to be stated what did they do and that they're acknowledging that there is this issue and here's what the next plan is for the patient. Are there any questions?
Yeah, thanks, Candace. As always, great job. I'll remind everyone, if you've got questions, please go ahead and use the window on your GoToWebinar panel. There have been a couple that have come in already. So let's see, the first, if I can kind of paraphrase here, there are a couple questions just relating to next steps, like if it's the next 30 days or if a practice is to get going with implementing HCC. What advice or what recommendations would you give Candace around next steps?
So my recommendation for next steps would be to audit the provider documentation from an HCC perspective. So when we're performing audits, we see a lot of times where providers are using unspecified codes, still to this day. So making sure that you're looking at the documentation from an HCC perspective, as well as, in turn, once you have the audit completed, providing education to the providers based on the audit results. That will help you prepare for HCC and ensuring that the documentation is going to meet when there's a risk audit that is performed.
Okay, very good. And then I think you may have just answered this one. There's another question. Should our providers have an annual audit?
Yes, it is definitely recommended. So an annual audit will help ensure that the documentation is complete from a compliance standpoint, even with not just diagnoses, but getting in a little bit to E&M leveling. You could be losing money based on what you're documenting from a diagnosis and CPT standpoint. So ensuring coding compliance and looking at your reimbursement risk is definitely recommended to have an annual audit.
Okay, very good. I don't think we have any further questions, so I think we can start to wrap up. On the next slide, we've just got a couple summary slides around Medical Advantage Group's CPC Plus set of services. Now, Candace, isn't it true that a lot of what we're talking about here, while it is an important component of the CPC Plus program, a lot of what you're talking about is relevant even outside of CPC Plus. Is that right?
Yes, that's correct.
Okay, very good. I know that we recognize a number of the names dialed in on the webinar today. I know you guys have seen some of this material already, but the net of it is, for those of you that are in CPC Plus, please remember, please know that Medical Advantage Group is here and happy to help give any guidance, any assistance across all of the different components of the CPC Plus program. Candace, if you skip ahead a couple of slides, maybe the next slide. Yeah, so if that link there, the medadgroup.com/CPC Plus link, there's information about the different CPC Plus tracks as well as the services we're able to provide. On the next slide, there's a link around just the webinar listed. Obviously is Candace's session here today, but I wanted to point out the link. We'll be doing additional events just as we roll into the future on any number of topics. Many of them are listed there, so you can check those out and register as you see fit. And then finally, contact information for those of you, if you'd like to talk to someone at Medical Advantage Group. For those of you joining us from Ohio, our business development person is Sherry Kent. For those of you in Michigan, it's Jeff McKay. Their information is listed there. And then finally, Candace's information is available on the last slide. So as always, on behalf of all of us here at Medical Advantage Group, thanks so much for joining us here today. Thank you, Candace, for a great presentation, very, very helpful as always. And we'll be following up shortly with a copy of the materials as well as a link to the recording of Candace's talk today. Thanks so much, and have a great rest of your day.